So I'm Jonathan Lindner. Monet, you want to introduce yourself?
Yes, I'm Monet Strachan.
The purpose of this webinar is essentially to offer you an opportunity to ask any questions related to the webinar content that was produced. As Alyssa mentioned, there are 6 different lectures on ASE University. This was a program that was generated by virtue of a unlimited grant from GE to produce really the basics of contrast ultrasound, going from the agents to the safety to the clinical application to the future applications. It is not necessary that you have to have seen every single one of these lectures in order to ask a question. So this is your opportunity to essentially get further information on the program to clarify any issues. And so what we will be doing is answering every single question that we can, either orally or written, and a document at the end of the program. Once we have had some time to answer every single question, we will post to the webpage as a resource all of the questions and all of the written answers that we've provided. So a question has popped up here, and I'll ask Monet to answer this one, which is, are sonographers routinely placing IVs for the administration of contrast agents?
Yes, and it sort of depends on what your institution allows and what part of the country you live in. However, most places are able to place IVs, and even in our own institution here in California, we do have a policy and procedure that allows sonographers and all allied health professionals to place IVs. So it really just sort of depends on what your institutional policies are and what's allowed within your own institution, as well as state regulations.
Yeah, that's about the same for us as well, which is we give a sonographer, we encourage them, but do not force them to take the course in IV placement. Just about all of our sonographers are capable of doing it, and that's extremely important for throughput for outpatients. You know, most inpatients already have an IV, but for the throughput, that is important. So please remember to put your questions in, type in your questions, and a question has just popped up, which is there any risk to the fetus for an expecting mom to have an agitated saline bubble study? So the answer to I'll go ahead and take that one. The answer to that one is there has never been any kind of case reports to damage to the fetus, either for agitated saline contrast or really for commercially produced ultrasound contrast agents. That being said, anytime that you're doing this in pregnancy, you always want to use about as little of anything as you can get away with, because you don't know whether you're going to find a right to left shunt or not. The at issue is whether or not you're going to influence maternal placental blood flow. Now, all of the ultrasound contrast agents that are commercially produced, have different pregnancy levels, which reflect not enough information known. However, I've actually performed a study with people who, at my institution, who are interested in using contrast to study maternal placental blood flow with ultrasound contrast agents, and we didn't have any kind of adverse events or any change in placental blood flow based on it. That being said, you do always want to be very careful and only use as little as you can get away with. And when it comes to the ultrasound contrast agents that are commercially produced, you have to do a full risk-benefit ratio. In other words, only give it if what we do is we only give it if it really is going to make a huge difference. Monet, there is a question that says, why has contrast not gained popularity in the OR during CABG to verify adequate revascularization? I know there was a lot of work done on this many years ago. You want to take that, or you want me to do that?
Oh, I actually am very interested in what you have to say. I do want to add one thing onto your previous answer. One of the things that we do here in our institution, when we do, because on occasion we do get asked to do a bubble study on a pregnant patient, and we do sort of, as you stated, you have not had any issues with that, and we have also not had any issues with that. However, we are more concerned about that perceived fear of having an issue with the baby. So if something does go wrong, sometimes that, anything that happens during that pregnancy gets blamed. So what we try to encourage, unless it's something really urgent and needs to be addressed right there at the time, we try to encourage that we would do that procedure and that bubble study or that left heart contrast after the baby's been born. And of course, that depends on where they are during their pregnancy. So just sort of a follow-up on that.
Yep. And by the way, I would, along those lines, I would probably also avoid agents that are contraindicated with blood reactions. So I would stick with the lipid agents and avoid the albumin agents, just because of theoretic issues. So this issue with the contrast during CABG. So to give everybody a little bit of background, 15, 20 years ago, there were some studies published showing that contrast could be used in the OR, not just to determine whether or not there's been adequate revascularization with arterial or venous conduits, but actually also to assess the adequacy of cardioplegia. We squirt high potassium solutions down the coronary arteries to arrest the heart during CABG, and if that's incomplete, you can have ischemic damage. The main reason why this has never really taken off is two things. Number one, in order to get decent signal-to-noise ratio for doing perfusion imaging in the OR, you really can't do it with the TEE probe. The TEE probes are not well suited to high signal-to-noise ratio because of, for many reasons, aperture, frequency, lack of multi-pulse techniques for picking up the bubble signal. So you have to do it with a transthoracic, and feasibility of doing direct epicardial echo. It requires a little bit of effort and cost to have those resources available in the room. The second thing is really nobody had gone on to the next stage to actually show that outcomes were influenced by evaluating the adequacy of revascularization at that point in the OR. So hopefully I've answered that question. But the bottom line is if there is a key reason to really assess adequacy of revascularization in the OR to make a very important decision, there are data showing that can be done. Monet, there's a question that came through saying, please tell me the preferred echo settings for mechanical index, MI, depth, contrast for discriminating thrombus in the left atrial appendage with TEE. Can you get that one?
I certainly can. It's actually, it's very interesting. There was, it depends on which vendor you use and maybe a little bit on how old your equipment is. But historically, TEE probes did have a contrast, at least with one of the vendors, did have a contrast setting. So if you have the advantage of having one of those older transducers, the settings are already there and they do work fairly well. Now, some of these newer transducers, once they've embedded the 3D on there, they had to give up a little bit. And so in some of those newer transducers, when you have the 3D embedded on your transesophageal probe, it does become a little bit more complicated. So you would just follow some of the same sort of things that you would do with you would lower that MI down because there isn't those settings. You would bring it down to that 0.3 0.3 range, something a little bit, you wouldn't be able to activate those low MI imaging techniques because they are not available on the transducer, but you still do have access to impact that mechanical index just from the regular imaging. You would also likely need to use a little bit more contrast just because you tend to destroy and eliminate what's out there. And you just have to get that nice balance between, eliminating and attenuating, because it is that near field structure. It makes it a little bit more challenging. But we've had great success with it and using it when we've had sort of those questionable, maybe where it's sort of a gelatinous thrombus hasn't quite fully formed yet. But that's worked for us. Do you have anything to add?
No, that's exactly right. One thing is when you're operating with TEE, generally the SPTAs are a little bit lower and you're operating at higher frequencies. And the bubbles are, based on their composition and their size, are really well suited to ring at around the 1 to 2 megahertz range. And so generally you have to hit them a little bit harder, and you can get away with harder ringing without destroying them. Somebody asked, is it possible to analyze myocardial deformation by speckle tracking with contrast echocardiography and low MI. So there have been several studies that have been published on this issue, and the bottom line is if you're using a low MI technique with bubbles in the myocardium, the problem with speckle tracking is the bubbles will tend to come and go and move within the myocardium within the frame rate for doing speckle tracking. So it generally produces a little bit of a messy speckle tracking, and the robustness of tracking actually does go down, especially in the near field. So what I recommend is if you've got contrast in the cavity and in the myocardium and you want to do speckle tracking, go back to a non-contrast mode and crank up the mechanical index so that you're destroying most of the bubbles. If you do that, you'll essentially decrease almost all of the signal coming from the contrast agents, and you'll go back to actually having a much more robust speckle tracking algorithm. So you can do it, but you don't want to be in a contrast mode is the bottom line. Is there any standard recommendation about how many saline injections should be done to ensure adequate study is done? So this is about agitated saline contrast rather than commercially produced contrast agents.
Yeah, I would recommend, and in our institution, and personally, I would recommend that you do 2 injections. We do our first injection just because. And let me explain to you why. Because not only are you looking, at least in our institution and with our patient population, not only are we looking for intracardiac shunts, but we're also looking for arterial venous malformations out in the lungs. And so from our perspective, we want 2 injections. We want to be able to see that first injection. We want to see if there's any arterial venous malformations. So we tend to look at that injection in that bubble study for much longer to see if we have any delayed contrast coming in after it's already circulated through the pulmonary vasculature. The second injection we do is with a really strong Valsalva to try and get any shunting that might come across from the atrial, the intracardiac side. Do you have anything to add to that, Dr. Lindner?
Nope, that's great. There is a question that says, do you need to do a bubble study, meaning an agitated saline contrast study, prior to injection of one of the commercially produced ultrasound enhancing agents? So, and this actually harkens back to a comment that's actually been posted on the chat, which is, it is true that the FDA removed the right to left shunting as a contraindication to ultrasound enhancing agents based on safety data that has been generated. Let me give you a little, before I answer that question, and then I'll ask Monet what the practices in her laboratory. Let me give you a little bit of background of where this all comes from. So what happens is for almost all of the ultrasound contrast agents that are commercially produced, a very small proportion of those of that agent, generally less than about 2%, is larger than 5 microns in diameter. Now, your systemic capillaries, so the smallest blood vessels kind of in the tissues of your body, are right around 6 microns or so. So when you do an intravenous injection and you do not have a shunt, any bubbles that are large enough to become lodged, the ones that are kind of bigger than the size of capillaries, will lodge in the rather large plethoric and low impact microvessels of the lung. So they won't create any kind of major problem in the lung. And that even applies to patients with significant pulmonary hypertension. However, if you have a right to left shunt, then some of those ultrasound enhancing agents that are larger than 5 to 6 microns will make it into the systemic circulation and could become lodged in more, shall we say, intolerant microvascular beds, such as in the heart or in the brain. And remember, these ultrasound enhancing agents are much more stable than agitated saline contrast. An agitated saline contrast agent, which is formed from oxygen and nitrogen in the air, dissolve very quickly. The gas actually, they're not encapsulated, and nitrogen and oxygen are very diffusible, so they go away very quickly. So the ultrasound enhancing agents are much more stable and will lodge and create a situation where they could obstruct flow in a microvessel for up to about 5 to 10 minutes. I did some of the original rheology studies for approval of one of the contrast agents, Definity, and we actually modeled and looked at how long bubbles would actually stick in the systemic circulation if they made it out there, and it's, on average, it's just a couple of minutes. The bottom line is so few of those agents make it over to the left side and are evenly distributed through the body that they really don't create much of a problem. That being said, you don't want to use a huge amounts with a very large bolus in somebody who has a very large right to left shunt. So that we actually have a good safety margin, what we do is we do not do an agitated saline contrast agent on just about anybody. However, if somebody has unexplained RV enlargement or any other hallmarks of a large amount of a right to left shunt, we may do an agitated saline contrast first, just to make sure that we don't have any issues with safety margin of giving, a large bolus of ultrasound contrast agent. So in summary, almost never do we use right now an agitated saline contrast study prior to doing ultrasound enhancing agents, just in situations where we have really evidence that there could be a significant shunt physiology. That being said, you should be doing that anyway as part of your echo. Monet, any comments on that?
No, we definitely don't do a bubble study before we do our left heart contrast, and sort of regardless of what the patient has and what's going on. But in general, we also, with we won't do bubble studies in our congenital patients. However, we do LV contrast in our congenital patients, but we do use a very small amount in those particular patients just to be on the safe side, as minimal as possible.
Yep. And because of that, that's one situation where we actually use low dose infusions rather than bolus injections because it's much more kind of controllable.
Yeah.
Somebody has asked, we're getting a lot of questions, by the way, so I want to reiterate that we will be doing our best to address all of these questions, but every question we'll try to answer. If we can't on this webinar, we will answer in writing on a document. So somebody has asked, by the way, what we just addressed, somebody had asked, is it safe to perform a contrast study in a patient with a diagnosed PFO? And that essentially what we just said applies to that. Yes, it is. Can I study myocardial perfusion with low MI in 3D stress echo? All right. So here is, without going into too much physics that will put everybody on the webinar asleep. The 3D ultrasound probes that have been generated have not really been optimized in terms. So anytime that industry produces a new transducer and a new platform, there has to be optimization for contrast, both for LVO and for myocardial perfusion. At issue is the following, which is the 3D transducers, by virtue of how they shoot their beams, much larger, smaller F numbers, larger beam, fatter beams, and wider spacing of the elements, it is not conducive to actually doing really good high signal to noise ratio contrast imaging. Because of that, really some of the vendors have just gotten through optimizing contrast for left ventricular opacification for 3D. I am not that hopeful that we will actually have good myocardial perfusion for 3D, nor do I think we should be doing it. And the reason is the following, which is, if you do myocardial perfusion with 3D echo, the quantitative perfusion has to include a destruction and replenishment sequence. Okay, so for those of you who are unfamiliar with how we do perfusion imaging, to get the quantification, we destroy all of the bubbles within an ultrasound sector and then watch their reappearance back into the ultrasound field. The problem is when you have a 3D transducer and you try destroying all of the microbubbles in the field. And if everybody takes a look at their screen, I've actually put up there an image kind of showing the kinetic model that we do with perfusion quantification. The problem with 3D transducers is when you do a destruction, you not only destroy the bubbles within the myocardium, but you actually destroy all the bubbles within the LV cavity. When you've got a 2D transducer, that's a thin plane. With 3D, you've just obliterated the whole cloud of bubbles in the LV cavity. And all of those bubbles were supposed to make it up to the aortic root, down the coronary arteries, into the microcirculation within about 2 seconds. And so because of that, you will distort all of your data, 2 to 3 seconds after the destructive pulse, because you produce a negative impulse that essentially takes away all of your myocardial contrast. So for the near term, at least, until we can control these things, most of perfusion imaging really should be done with 2D transducers where signal to noise is optimal, where multi-pulse algorithms are used to increase signal to noise ratio, which would be kind of a disaster with 3D probes. So hopefully I answered that one. And if there's any other questions as far as that goes, please just type in a subsequent question. All right. I have a question. Monet, why don't you consider this one? I am a nurse sonographer working in cardiology case management prior authorization. Do you submit prior authorization requests for additional echo if repeat imaging is needed, and are the requests authorized? Do you need to, you want to address that one, or?
I'm a little bit confused on this. Is this like I'm not seeing the question in here, so forgive me for asking you. But does it state whether this is additional imaging as if the patient had to come back for contrast, or is?
It looks to me that they're referring to additional echo images with contrast or repeat imaging. If somebody needs to come back. So do you need a prior authorization?
If you're going to build a patient a second case, then yes, I would recommend getting another authorization. However, chances are one of those studies is not going to be paid for, or at least a portion of that study is not going to be paid for, in my understanding.
Our policy is if we have not done contrast, and we should have done contrast, and we bring the patient back specifically for contrast, we do not charge, because that's usually somebody making a call or an interpretation and saying, this is inadequate. So we actually do not do that because of that, we do not, because we do not additionally bill, we do not go back for another PA. Now here's the problem, which is coding for contrast. So for those of you who don't know how coding is done, you don't need you're not going to get anything for inpatients because of DRG policies in the United States. But for either HOPS, APC billing structures, or for CMS reimbursement coding, generally what you do is you just code for a comprehensive rest echo, if that's what you're doing, or a stress echo. And then you add on the HCPCS C code. In this case, for rest echo, the C code is 8929. For stress, it's 8930. And then the Q code for the contrast agent. So those are the additional things that you need to do so that you can get reimbursed for using the contrast agent and your additional time. The problem is if you've had to bring that patient back and you're not rebilling them, generally you can't go back and add on those codes for additional reimbursement. So it really does behoove you to get things right the first time. All right.
Yeah, and I agree. And we don't go back and bill patients for the second time if we've, like you said, if there was a situation where we did not do the complete study the first time, or as it should have been done the first time.
Yep. So Monet, there's a question here, number 18 here. What data is available on saline injection and TR velocity jet? My sense is that it can be very helpful. Is there any evidence that it may result in an overestimation of the gradient? So you want to give some hints on how best to optimize agitated saline for, and generally this is for agitated saline.
Yeah. For agitated saline, basically if I'm going to use that to get my TR jet, it it does enhance the signal, and you have to be really careful because it can have a little bit of blooming and bleeding of that signal. So you'd really want to take that dark modal velocity, not like those little outliers that kind of come off the fringe. I would also do it sort of at the very end when most of your saline has already left and where you have a very little bubble effect. And I think it can be helpful on those really challenging TR jets. I also don't think that you should just limit this to saline. I think that we can also do that with left heart contrast. But one of the things that I think people tend to forget is that you should still use all those wonderful tools that we use when we're using 2D imaging. You should bring down your mechanical index in the Doppler. You should also bring down some of those gains and other settings that we have, or other tools that we can use to sort of get that nice balance between the signal.
Yep. Yeah, and I want to reiterate what Monet just said, which is, you're going to have a complete a blowout of your signal if you do a big contrast. And so generally, if we're doing agitated saline contrast to rule out the shunt or something along those lines, we essentially wait until we barely see any kind of bubbles whatsoever on the right side. It's amazing how few cavitation nuclei it takes to enhance a Doppler signal. So don't go wacko on it. And then when you're using the commercially produced enhancing agents, we generally have turned off the infusion, or it's a long time since our last bolus injection that we start getting our TR jet signal for the same reason.
Exactly. And you can even turn on your regular imaging mode to eliminate some of this contrast that's in the cavity if you don't want to sit there and wait too long.
Yep. Monet, so there is a question for us, having discussed using contrast agents during pregnancy. Are there any posted age restrictions for pediatric age groups? What's really nice is the several pediatric groups that have been interested in using contrast ultrasound really as a research technique to study, for example, right ventricular myocardial perfusion in congenital heart disease, and for other interesting applications in pediatric populations, have done some very nice studies looking at the safety of contrast agents in kids. And thus far, as I know, there has been absolutely no safety signal whatsoever. Pediatric echocardiographers generally don't use the commercially produced contrast agents very, very much because, well, quite obviously, generally the kids have better image quality. There isn't the issue with endocardial dropout. There isn't the question for left ventricular thrombus as often. That being said, with the increasing prevalence of obesity in our pediatric populations, I think that's about to change. But for example, using it to exclude the presence of a thrombus in somebody who has a surgically corrected a congenital lesion is something that I've seen our own institution use it for. Monet?
Yeah, we certainly do a lot in our adult congenital. Now, for us, our pediatric cardiology is really just a NICU. We actually have an agreement with our local pediatric, our local children's hospital to send anybody that's between the ages of newborn and 13 over there. And I know that they do not use contrast for their left, for looking at the from the cardiac aspect. Now, of course, there are some agents that have different, that have been approved for different uses in the pediatric population, but certainly it's not approved in the cardiac arena yet. But that's interesting that you know of some safety studies. I hadn't heard about that. That's great.
Yeah, Kasia has published some studies. So I get updates on these. I go to the Chicago Bubble meeting every year, and for the last couple of years, there's been updates on pediatric uses and pediatric safety. So that it is being used increasingly by the pediatric population. Now here's an interesting comment. Is 3D contrast echo now better than 2D contrast echo for left ventricular opacification just to see myocardial wall motion. So my answer to that is you can use it with 3D. It is optimized for some of the vendors. My own personal opinion is it is not as good. So the at issue with 3D echo, in order to see wall motion, you need to have frame rate. And in order to get frame rate decent when you're essentially rastering, so for those of you who don't know the term rastering, essentially with a 3D probe, what you do is you shoot one line of ultrasound and then you move in the elevational direction to the next line and the next line and the next line. If we did 3D echo just like we do 2D echo, we would have frame rates of about 3 frames per second. So what happens is there's engineering that has gone into these systems for more kind of retrospective beamforming to be able to figure out where pixels are coming from after shooting fatter lines. That being said, because of these larger three-dimensional, these larger lines that we're shooting, the spatial resolution still is not quite as good, nor is the temporal resolution quite as good. So right now, I would say that I still prefer 2D to 3D echo. The second thing is that sometimes attenuation is still a problem if you use too much contrast agents. And one of the things that is really nice to be able to use when you have attenuation from the LV cavity to see the far field wall motion is some of the more advanced bubble-specific modes. Instead of just harmonic imaging, going into the multi-pulse modes like power modulation or pulse inversion imaging, the low MI contrast imaging modes. And those are not really available on the 3D systems, mostly because you need to shoot several lines for every line. You need to shoot several pulses in order to get that data, and it's just not conducive to 3D imaging. So right now, I still prefer looking at wall motion with 2D than 3D, just because of the spatial resolution is better. Monet, do you agree?
Oh, I wholeheartedly agree. Yeah, that's kind of been our same experience here.
Yeah. I've got. Let me pass this one to you for on this one. I have several questions that have asked. Actually, 2 things. Number one, somebody says, "Do you have a slide with billing codes?" I'll go ahead and pull that up for you guys now. While I'm doing that, Monet, why don't you attack? Is there a specific administration protocol? What would be the situation to use blood in saline contrast studies? So several people have said, do you want to pull up a little bit of blood to mix in when you're doing agitated saline contrast?
Yeah, well, it definitely will help in terms of getting you that contrast effect. However, I am a little bit cautious personally in doing this just because of the potential for the biological risk. I don't know. I've been in the field for quite some time, and we have a variety of people that will be injecting. Sometimes we use our fellows, sometimes we use, various other people that can do that in our institution because our sonographers are not currently allowed to inject. And so, you tend to grab anybody, and if somebody hasn't quite hooked up that lure lock perfectly, you have that potential for splash. And so, although it does work really well, I think that there's some risk with that maybe is not necessary. What we have found in our institution is, and I know a lot of institutions have gone to these prefilled syringes. Well, these prefilled syringes do not use bacteriostatic saline, and you need that surfactant in the bacteriostatic component to create that nice bubble enhancement. And so what we have done in our institution is we have gone back to pharmacy and say, we can't utilize these prefilled syringes. We need the bacteriostatic saline, which they aren't always eager to give up because that's what they tend to use in their compounding. But that's what's worked best for us. So we just specially order for our department that bacteriostatic saline that comes in the vials as opposed to the prefilled syringes.
Yeah. So I want to reiterate what we have the same policy in our lab, which is the sonographers really are not allowed to do that without kind of some supervision, and that's mostly for their own protection. If you are doing it, you just got to make sure that you have maintained appropriate PPE, personal protective gear, including gown and eye cover, if you're doing that because of the turning of the syringe the wrong way and getting a splash. That being said, the reason why blood actually works is when you agitate saline with blood, you actually have a surfactant in there, which is albumin and some other proteins as well that can serve as surfactants. And so it tends to stabilize them. There's other things that you can do to make your agitated saline contrast studies a little bit better. One of the things that can be done is putting an IV in the lower extremity. When you shoot it into an arm vein, it comes in through the SVC, and sometimes there's a problem with people who have, for example, prominent eustachian valves, having all of the IVC blood coming in and hitting the interatrial septum and essentially diverting blood coming in from the SVC. And so in those kinds of situations, a lower extremity vein can sometimes help. I've got the contrast billing information, one of the slides up there. So this shows you kind of the differences between hospital, HOPS, and individual physician reimbursement. And then here's some of the CMS reimbursement codes. For example, for a resting transthoracic echo, I've got the standard CPT code. Then you have to add in the HCPCS C code, which would be an 8929. And then the Q code essentially is a link to the different contrast agents. And that's Q99 55 through 57, or now Q9950 for sulfur hexafluoride. When you do this, by the way, you do not report any additional Q codes or C codes with IV insertion or injection procedure. It's covered by the C code, the 8929 code. And down at the bottom is just an example of, this is from 2018, that these things are about to change, but really minimally. And it just shows that you are, if you add on that C8929 associated with contrast use, you are not penalized for using contrast in the outpatient setting. All right. Here's an interesting question. So, is there a specific administration protocol to assess non-compaction? So, Monet, why don't you start with that one, and I'll chime in if
perfect
with my thoughts.
All right. So for us, when we're assessing a patient for non-compaction, we actually do this over 2 injections for each view. So our first injection that we'll give is sort of, if I were looking at a normal ultrasound enhancement agent study, I would say that this was too low. So we give a very small injection where we sort of send poofs of contrast through those deep recesses of the non-compacted myocardium, and it helps us to sort of get a sense of how the recesses are, where the endocardium actually where that endocardium starts, and where that non-compacted myocardium, how extensive that is. And then once we've sort of gathered that information, we'll go and do what would be like a full, heavier injection, where we get a nicer delineation of that compacted myocardium. And so that helps our doctors sort of to differentiate whether this is a true non-compaction or just maybe a heavy trabeculated cavity.
Yes, here's the deal with non-compaction. So there's a lot of cardiomyopathies, burnt out hypertensive cardiomyopathies, certain form of muscular dystrophies, where you can have prominent trabeculation, especially at the typical areas that we look for non-compaction at the apex and the apical lateral wall. The criteria for non-compaction require you to be able to measure the compacta and the non-compacta. And the ratio. And there's different criteria. Some of them are during systole, some of them are during diastole, in terms of making that determination. The key thing is you have to be able to reproducibly measure where the compacta and non-compacta end and begin. And so because of that, one of the things that we tend to do is, and if you use too low of an MI and just get standard LVO, sometimes you don't see the non-compacted portion in the apex. It kind of disappears into the cloud of echoes. And because of that, we tend to use a little bit higher of a mechanical index so that you can actually see with systole and diastole the contrast coming in and being squeezed out of these intratrabecular recesses. And so I anytime that it's being considered, I highly recommend using contrast to delineate where these things happen. The other thing is that, the compacta is really thin. Some of the criteria say that you need to have a compacted myocardium of 0.7 centimeters or less. And very often that's really hard to determine when you've got this heavy trabeculation. So I think it's a great situation to use contrast. Monet?
I agree. And I like your idea of a little bit higher MI so that you can actually get that, the wall, the epicardium as well as the endocardium. And that way you can really see how thick that wall is.
Yep. So Monet, question number 30. Do you feel that bolus dosing gives you better images than an infusion, or is there too much attenuation if bolus dosing is used? You want to tackle that one, or we'll probably double up on this one. Why don't you go first?
Absolutely. So for me, you know what? I do a lot of teaching out there, and I do try to encourage people to do what works best for your institution. So every injector is going to be a little bit different. Your system settings are all going to be a little bit different. So I figure out what works best in their institution for their situation. And I think it also depends on what it is you're looking for, and I might be overstepping what Dr. Lindner is going to talk about. But if you're looking more to get a nice steady state and a continuous, like for perfusion, you want a nice continuous infusion, where when you're doing those boluses, you tend to get a peak and then a valley and a peak and a valley. So to me, it's nice to have, I would use them for different reasons. But if you're just talking about doing it for LVO in your own institution, I would recommend testing out a couple of different ways to see what's going to work best for your whole setup and everything that you have in your institution.
Yeah. So yeah, I agree completely with that. Here's a couple of additional points. So certain of the contrast agents are better suited to infusion than bolus, or rather the other way around, that are better suited to bolus and really are not well suited to infusion. A good example of that is Lumason. So Lumason really does not lend itself well to being diluted and put into a infusion syringe. So it's generally done with hand boluses. The other contrast agents, especially Definity, is better. And I'm just telling you based on without any kind of bias to one contrast agent or another. This is my 25 years worth of experience or 20 years worth of experience with these things. Definity actually does better with dilution and being put into a big syringe that you can do a continuous infusion. Now, here's our policy, which is if you just need a couple of quick images of LVO, then a bolus is fine, although you are susceptible to having attenuation. And you can get rid of the attenuation faster if you turn on color Doppler or just crank up the MI to destroy some of the bubbles in the LV cavity. When you are doing stress echo or you are doing myocardial perfusion, infusions really are quite helpful. Our sonographers, I tell you something, most sonographers, if you tell them, well, you have to set up an infusion to infuse in the contrast agent, sounds like a lot of trouble. Our sonographers love it and will not go back to doing bolus injections as their preference. And the reason is they've gotten really, really quick and good. It takes them about a minute to get set up for an infusion. That's about it. And once they're done with that and they start the infusion, they don't have to keep on going back and forth, putting the transducer down, doing an injection, doing a bolus, imaging, waiting for attenuation to go away. So they love it. And so for stress echoes, it really is quite convenient to just have a continuous infusion where you can do your dobutamine or stress echo LVO without having to worry about going back and forth for the injections. And for myocardial perfusion, it is critical. It is critical that the imaging is done with a constant blood pool concentration of microbubbles. And that's really best suited to infusions, in my opinion. So hopefully we answered that question well.
Well, I have a follow-up question for you. How is it that you are doing your infusion? Are you infusing from a syringe or bubble in a bag?
Yeah, so good question. So here's what we do to make things really kind of high throughput in our laboratory. So all of our echo systems are coupled with a handheld infusion pump that is a syringe infusion pump. And so all you have to do is to essentially pull up some saline with the contrast agent. So we usually dilute it. Then we have a extension tubing to put into the IV. So what the sonographers do at the beginning of the day or the beginning of the week is they make up infusion packets. So in a little plastic bag, individual plastic bags, in will go 50 ml bag of saline, a spike for getting into the contrast agent, extension tubing, all of the things that we essentially need to set up a infusion, so that when we need to do contrast, they just whip out one of these little packets, these baggies. Everything is there that they need, including an alcohol preps or two. And essentially, they just take everything, assemble it, pull the contrast agent into for example, a 30 cc syringe. So if you take a vial of Definity or a vial of Optison and dilute it into a 15 or 30 mLs, then you can run it at 60 or 90 mLs per hour and have really nice LV opacification as well as perfusion. All right. Somebody has asked, how do you alter your dosing and administration for central line? So, Monet, why don't you take that one? I'm going to have to mute my phone while a helicopter comes overhead.
So for us, when we're utilizing a central line, one of the things that we find is that your doses it's got to be reduced. And your effect does not last as long. So likely you'll have to give a little bit less contrast than what you're used to, and you'll also have to give it a little bit more often, a little bit more frequently, to definitely try and keep that contrast effect. Obviously, with the central lines, you're going directly into the heart, so you tend to get a little bit more attenuation. You maybe have to be prepared to implement some of your higher MI destructive sequences to go ahead and get that nice lower, when you come back into lower MI imaging and get that nice homogeneous fill. Do you have anything to add, Dr. Lindner?
No, that's kind of exactly right. I just highly suggest that you coordinate this with the ICU nurses, since that's generally where these folks are, and just make sure that you flush all the contrast agent out of the central line when you're done with it. Make sure it's adequately flushed with heparinized saline. By the way, there is a tab on the left side of your screen that is resources. I have not added anything to that tab. The one thing that I will do, since there's been a lot of questions about pediatric use and safety, there's been questions about right to left shunts. What I will do is, when we are done with this webinar, is I will post to the resources page some of the studies that are key to understanding the safety in kids and right to left shunts. The other resource that you can go to for that, of course, is the ASE guideline document that was published. First author is Tom Porter on that one, and that was in 2018 on the clinical applications of ultrasonic enhancing agents in echo. It is a document that is rich in information, but also rich in references that point to the key data on safety. So as we continue on, here's an interesting one. And again, we're going to try to answer all of these questions as a resource. So even if we don't answer your questions audibly, the written responses will be available. So somebody has asked, after you have reconstituted or mixed a vial, how long can you still use that vial? Monet, you want to attack that one?
Yeah. Well, I Yes, both of them actually. There was one just above it. Do you use a vial for more than one patient? And I think that those two kind of go together. Yeah. They are single-use vials. You should only be using one vial per patient. Now, we all know that oftentimes when we do a study, we'll have leftover contrast, but that doesn't mean that we should go use that on a different patient, just for a multitude of reasons. But for safety as well as legality. In terms of billing and that sort of thing. And then after you've had a vial mix, now it depends on what you mean for mix. Now, if you're talking about like DEFINITY where it's been activated in the vial mix, there is definitely like a long period of time where you can reactivate that agent and be fine to use it again. If you're talking about once we've pulled up saline and sort of mixed it into a suspension, then that's a little bit different because once you've mixed any of the agents into another, say saline or some other liquid, it starts that gas exchange, and so it's not going to be a viable agent for an extended period of time. And personally, in our own lab, we tend to use any like if we've mixed up a syringe. We ideally like to use it within about 15 minutes just in case, because we don't really necessarily want to have it in those critical time points, say during a stress study, and not have a good effect. What is your thoughts, Dr. Lindner?
Yeah, about the same. So there's one other issue, which is the different agents have different amounts of air, nitrogen and oxygen in their headspace. And when you mix up an agent and you tap into it and then introduce air into the headspace, there can be something that if you're a nerdy bubble physicist that we refer to as rectified diffusion, which means that you can actually get more gas entering into the bubbles and they can become larger. And then all of a sudden, all of the safety data with ultrasound contrast agents in vulnerable populations with shunts or pulmonary hypertension kind of goes away. If you leave it too long, and that does happen. So my suggestion is, not to leave the stuff sitting around for too long. If you've activated, for example, DEFINITY and haven't tapped into it, generally you can use that for up to about an hour. But if you've had to reconstitute stuff, I'd use it kind of right away. Here's an interesting question of using contrast with higher frequency transducers. Have we done it? So here's the party line on that one. The bubbles are really tuned based on their size and their what's called their elastic modulus, their stiffness coefficients are really tuned to giving you maximal signal at around 1 to 2 megahertz. That being said, they can be used for higher frequency. So it really depends with that question, how high frequency are you talking about? So if you're talking about, for example, the ultra high frequency transducers that people are using with preclinical imaging, the 40 megahertz or 35 megahertz transducers, the signal to noise on that really is quite poor. And the manufacturers of those preclinical devices have started developing bubble specific modalities that are based on multipulse, but they have had to go down to frequencies less than 20 megahertz in order to get that done. If we're talking about things more like linear array transducers used for vascular imaging that are operating at 5 to 12 megahertz, for example, the contrast agents actually can still ring and give you a good signal using those transducers. Most of the manufacturers are developing, because there is interest from the vascular ultrasound people, there's interest in using contrast agents for better delineating plaque in 3D or better imaging vasa vasorum, for example. Most of the manufacturers are developing bubble-specific modalities or already have for linear array transducers at higher frequencies. And of course, the worldwide contrast is used by many people to evaluate liver, and that's generally done with higher frequencies in the range of 3 to 7 megahertz as well. So you can still get nonlinear signal out of bubbles at higher frequencies, but it really does tend to go away once you're above around 14 megahertz or so. Hopefully I answered that question. We're going to try to do, time is kind of running out. We'll try to do about 2 or 3 more questions before we finish up. Monet, there's a question. Is there a time interval of minimum distance from acute myocardial infarction for safety reasons?
I'm not aware of any. And I think you might be able to tackle that question. I know some of the European sites had done a lot more of that data than I have in our institution.
Yeah, the answer to that is no. There's no concern whatsoever. If you have a patient who, for example, is in the ED or presenting with MI and you need to use contrast to see what's going on, you use it. There's no special safety considerations for patients in the midst of having an MI. As a matter of fact, we did a single center study of over 2,000 patients with suspected MI. And I did a study myself where I did contrast perfusion imaging of patients on the cath lab table, looking at myocardial perfusion before and after primary PCI for MI. And there's just no safety signal to say that it should be withheld for patients with acute MI. So it can be done and it should be done. Let's see. Any other questions that you see, Monet, that we should answer before we conclude this?
No, I think we've gotten sort of the gist of all of it. I think a lot of them are sort of repeats and similar to what we'd already answered.
Yep. So what I will do is I will gather with Monet. We will split up all of the questions that we believe have not been answered adequately, and provide those as a resource on the webinar page. I will also post some of so if you don't want to go into the ASE guidelines document for ultrasound enhancing agents or contrast ultrasound, I have no idea why you shouldn't, but if you don't want to, I will post some of the key articles on safety in shunts and pediatric populations for people to reference as well. So, Monet, any concluding comments from you?
Nope. I'd just like to thank everybody for spending the time with us and giving us such great questions.
Yeah, I want to reiterate that the questions were superb. If you haven't accessed the 6-lecture series online on the basics of bubbles, please do go into the ASE University to access that. There's some older contrast material on the website as well, so you'll just have to look for the program that says Basics of Bubbles. And it's a very resource rich. There are about 25 to 35-minute lectures. They have CME questions that are associated with them. So a lot of time and effort was spent on getting these programs together. Alyssa, do you have any, if you're on the line, do you have any final comments from ASE staff perspective?
Well, I just want to give a very special thank you to you, Dr. Lindner, and to you, Monet, for presenting on behalf of ASE, and thank you to everybody else who is participating today. And also, just as Dr. Lindner mentioned, we'll upload the questions unanswered to the event page on ASE University once it's available. So be sure to keep up to date on future live webinars by checking the ASE University homepage. Thank you, everyone, and have a great day.